A very good evening to all. My name is Dr. Vikas Deswal, and I am an infectious disease physician at Medanta, the Medicity, Gurgaon. So today we'll be talking about a burning topic of invasive mucormycosis in patients with uncontrolled diabetes. Invasive mucormycosis is a devastating infection, and if it is not tackled and identified properly on time, it leads to significant morbidity and mortality. It is an infection which is associated with mortality up to the tune of 60 to 90% in many studies. And if we don't identify and treat it properly, the mortality is as high as 95%. So before moving on to my talk, I would like to thank all my alma mater where I have trained or worked, and also the Clinical Infectious Disease Society, which I am a member. I have no disclosures to disclose to anyone, and this is the outline of my talk. First, I would be to make the presentation interesting. I have divided my talk into few cases. I would be discussing three cases, and along with that, I would discuss the mycology of the mucormycosis, epidemiology, the hosts who are at risk of developing mucormycosis, and the various syndromes which are produced by mucormycosis. Also, I would touch upon the treatment and the prognosis of the mucormycosis, and in that we will end with take-home message for everyone. So I'll quickly go to the first case. He's a 54-year-old Mr. X from Kanpur. Is a known case of diabetes mellitus and hypertension, and is not compliant with therapy for the past 6 months. He presents with a right-sided hemicranial headache since 2 weeks. He has hemifacial pain and swelling on the right side of the cheek since 2 weeks. He has loss of vision and tosses of right eye since last one day. Examination reveals a right eye proptosis, chemosis with no extraocular movement, and no perception of light. Oral cavity, there is a necrotic lesion on the palate. I'll just show you the image of that. And the other systemic examination is unremarkable. So we can clearly see a necrotic lesion in the hard palate of the oral cavity, and there was no vision. PL was negative, PR was negative, and it was like a fixed globe. All the extraocular movements were not there. So these were his initial labs. His hemoglobin was 13.3, TLC was 12,000 with a neutrophilic predominant of 90%, creatinine was borderline, it was 1.4, LFT was normal, and his hemoglobin A1C was 12.3, which is over the roof. And RBS on presentation was 448. ABG revealed a metabolic acidosis and urine ketones were positive. His ECG was normal and viral markers were negative. X-ray PNS, which was done in the emergency room, showed some maxillary sinus thickening, and there was no fracture of the bones in that X-ray PNS. So we got an MR and the CT of the MRI of the brain and the CT of the PNS, and the MR showed orbital thickening, and we can clearly see on the right side there is proptosis, right-sided proptosis, and the extraocular muscles are there is fat stranding of the extraocular muscles, and they are thickened. And on the second image, we can see that the maxillary sinuses on both the sides are almost full, and here we can see some bone erosions also, which is fairly typical of an invasive fungal infection. In invasive fungal infection, you would invariably see that sinuses would be full, and then you would see the bone erosions, and then they would go in all directions. If you have involvement of sphenoid sinus, it would end up in cavernous sinus. If you have involvement of frontal ethmoid sinus, then it would end up in frontal lobe, presenting as cerebritis or frontal lobe abscesses. So, in further course in the hospital, his glycemic control was optimized, his acidosis was corrected. He undergoes a FES and a right-sided evisceration to control the source, and all the tissue and tissue was sent for cultures and histopathological examination. And not to our surprise, it came back as angioinvasive mucormycosis. We can clearly see in the histopathology that there were broad aseptate with right ankle branching hyphae seen, and angioinvasion was also noted in that. So biopsy from the orbital content as well as from the nasal cavity was consistent with mucormycosis. On the other side, we can see the histopathology slide in which we can clearly see that there is a broad aseptate hyphae, and which is like a ribbon, which we can differentiate depending on the size of that or the diameter of that hyphae from aspergillus. The mucor hyphae are usually 5 to 15 micrometer in diameter. They are mostly pauciseptate and sometimes completely aseptate also, whereas the aspergillus hyphae are they're narrow. The diameter is between 3 to 5 micron, and they have septate. So important point here to remember is that whenever you are suspecting mucormycosis, it is important to not grind or cut tissue when we are sending that sample to microbiology lab, because these hyphae are aseptate. They would break or they would fold up, and we would end up missing the diagnosis, and that would be catastrophic for the patient as well as the doctor. So his diagnosis was a rhinoorbital mucormycosis in a poorly controlled diabetic host. He received liposomal amphotericin for 4 weeks, and we followed that up with posaconazole for 4 months. Also, we made sure that he has a strict glycemic control, and his A1C was brought down to below 7.5 over the next 3 months. So, what are the various clinical presentation of rhinoorbital mucormycosis? It usually presents with unilateral headache. The patient would complain of pain behind the eye. The patient would complain of facial pain. They will have proptosis, and they will have visual disturbances. They can present with both cavernous sinus syndromes as well as orbital apex syndrome. Also, we can, in many cases, we can find necrotic lesions on the hard palate or the nasal mucosa. And in the nose, you will find nasal congestion, nasal discharge, which would be black in color. Also, the patient would have findings suggestive of acute sinusitis. And since this is an angio-invasive fungus, you can have epistaxis in many cases also. Systemic symptoms, fever is invariably absent in these patients. Very rarely they have fevers. So how does the rhino-orbital or rhino-orbitocerebral mucormycosis progress? The first stage is the infection of the nasal mucosa and the sinus, and from there it involves the orbit. It can cause orbital apex as well as superior orbital fissure syndrome, as I discussed earlier. Stage 3 is when it involves the cerebrum, and there is intracranial spread of the disease. It can occur from the ethmoid sinus. It can go into the frontal lobe. From the sphenoid sinus, it goes to the cavernous sinus. And the various other routes which it can take is through ophthalmic artery, or through the superior orbital fissure, or through the cribriform plate of the ethmoid bone. So now, what is, by definition, what is mucormycosis? Mucormycosis is an aggressive angio-invasive fungal infection caused by filamentum fungi in subphylum Mucormycotina, which afflicts the immunocompromised host and those who have severe hypoglycemia. Also, it is important to note that diabetic ketoacidosis is an additional risk factor in addition to the hypoglycemia alone for patient having mucormycosis. Till past few years, zygomycosis was the term which was used, but of late it has been replaced by mucormycosis. Zygomycosis is further divided into two genus. One is mucormycosis, and the second is entomophthalmycosis. So zygomycosis is not equal to mucormycosis. Zygomycosis has now been replaced by mucormycosis in the latest fungal classification. And as I already discussed, the mortality is up to the tune of 60 to 90% in various studies. And if we do not treat it or diagnose it or treat it properly, then it is almost certain that we will end up losing the patient. So next week, go back to our second prof in microbiology. Mucormycosis is an ubiquitous fungi. It is present in nature everywhere. It is present in decaying vegetables and soil, and it is frequently isolated as contaminant in the labs. So we all are exposed to it on a daily basis, but very little of us have disease. So that means that most of us have intact immune system. And it almost always produces disease in those who have underlying immunosuppression or metabolic issues like diabetic ketoacidosis or very high blood sugars. What are the various species of mucor? They are Rhizopus, which is the most commonly isolated species, Rhizopus erizus, then mucor, Rhizomucor, Cunningamella, Lectinia, Apophysomyces, which is usually associated with skin and soft tissue infection post natural disasters or post RTAs. Mucormycosis are broad, pauciseptate, and they are irregularly branched, and their diameter is 5 to 15 micron. They are very fragile in nature, and they are difficult to grow because they are pauciseptate. Key point is do not grind the sample when you are suspecting mucormycosis before sending it to the lab. So next we move on to the epidemiology of the mucormycosis. It is estimated to affect 10,000 individuals globally, but the incidence in India is much higher because we know that the incidence of diabetes in India is much higher, and many of the diabetics in India are diagnosed very late in their disease. So the incidence of mucormycosis, as expected, is much higher than what is reported globally. Most affected individuals have poorly controlled diabetes or may have metabolic acidosis, or they may be immunosuppressed for other reasons, like anyone who's been exposed to high dose glucocorticoids, those who have prolonged and profound neutropenia. By prolonged and profound neutropenia, I mean that anyone who has a neutropenia which is less than 100 lasting for more than 7 days qualifies as prolonged and profound neutropenia. Rare cases also occur in immunocompetent individuals following traumatic inoculation of the sports, following tornadoes, blasts, road traffic accidents, or in burn patients. Outbreaks of mucormycosis have also been reported in healthcare settings, especially connected to the use of the wooden tongue depressors or the bandages which we use for dressing of our patients. So this was a study done by one of my close friend and colleague, Dr. Abhimanesh and his group. They studied the culture positive mucormycosis over 10 years, and they found that the Rhizopus erizus was the most commonly isolated species in Indian patients, and this which was 49%, followed by Rhizopus microsporum in 29%, and Apophysomyces elegans in another 11% of the cases. All the other species represented 16% of the isolates. The important point to remember here is that Rhizopus species is the most common species all over the world, and it is usually associated with rhino-orbital mucormycosis. So this is what I was talking in the previously. From this, we can clearly see that the Rhizopus erizus is responsible for 81% of the rhino-orbital mucormycosis. And this is, I'm talking only the culture positive cases over 10 years. Whereas look at Apophysomyces, which is usually associated with skin and soft tissue infection, and it is fairly common after road traffic accidents or in a patient with burn. We'll also discuss one case related to that later on in my presentation. So this was another multi-center observational study looking at the epidemiology and risk factors and outcomes of mucormycosis in India. They had this was done in 12 centers across India, and it had around 400 cases. And we can from this diagram we can clearly see that rhino-orbital mucormycosis is the most common site of infection by mucormycosis, followed by pulmonary, and then cutaneous and others in few numbers. The risk factors, as expected, are diabetes in up to 73% of the cases. Remember, in the study done by Dr. Abhimanesh also, it was up to the tune of 65%. Malignancy was seen as a risk factor in 9% of the cases, and transplant, especially the bone marrow transplant, was seen in around 7% of the cases. And there were many other risk factors which were also seen, which was around 9%. So it is not just the species of the mucor which is infecting, it is also the pattern of risk factor by which we can predict what sort of an involvement this predisposing condition would lead to. Suppose if you look at diabetes as a risk factor, so diabetes would most commonly present with rhino-orbital or cutaneous mucormycosis, whereas Malignancy would mostly present with pulmonary or cutaneous mucormycosis. Very rarely it can produce rhino-orbital mucormycosis also. Hematopoietic stem cell transplantation, the mucormycosis is seen in up to 1 to 2% of the cases. They would usually present with pulmonary involvement, and in some cases, disseminated or rhinocerebral disease can also be seen. Solid organ transplantation, the rate of mucormycosis is fairly low. It is around 1.1%, and they usually present with sinus or cutaneous or rhinocerebral involvement. In the intravenous drug user group, it is the mostly it's a bacteremic, it's a bloodstream kind of an infection. So you will have metastasis to different parts of the body, and the patient will have a disseminated disease. They can have cerebral abscess, they can have endocarditis, they can have skin lesions. So all sorts of manifestation can be seen in intravenous drug abusers because it is a bloodstream infection in them. Malnutrition usually leads to gastrointestinal or a disseminated disease. Therapy with deferoxamine, which is used as an iron on aluminium chelator, leads to a disseminated disease or a pulmonary mucormycosis, whereas post-trauma, mostly it is cutaneous or ocular. Now, let's look at what are the various modes of infection. As I discussed earlier, it is ubiquitous in the environment. It can enter our body through inhalation, through ingestion, or through the percutaneous routes following trauma, natural disaster, or combat. And the other subgroup is through nosocomial acquisition of the infection, which can be through contaminated bandages, contaminated tapes, needles, or tongue depressor. So let's look at who are at risk of developing mucormycosis. The first and the foremost important risk factor for development of mucormycosis is diabetes mellitus. Why diabetes mellitus people are at increased risk of developing mucormycosis is because of the following reasons. The first and the foremost is that in diabetics, especially those who are poorly controlled, have impaired neutrophil chemotaxis, and because of that, the neutrophil migration to the site of infection is very poor. Also because of the poor adhesion to the vascular endothelium, and also in poorly controlled diabetes, there is poor opson of phagocytic function of the macrophages. This leads to a disseminated disseminated disease. Now, what happens in DKA? DKA, we all know, is an acidic environment in the blood, and because of that, there is sequestration of the proteins, and because of that, free iron is released into the blood, and that free iron is food to the fungus. So, because of that, there is an increased risk of mucormycosis in patients presenting to DKA. In fact, around 10% of the patient in the study done in Vellore had presented with DKA of the mucor patient, which they encountered over 10 years. Now, what are the other risk factors other than diabetes mellitus? As I discussed earlier, treatment with glucocorticoids because they lead to defect in cell-mediated immunity. Hematological malignancies, those who have profound and prolonged neutropenia, the incidence is up to the tune of 1%. Hematopoietic stem cell transplantation, especially those who have a transplantation for AML or an aplastic anemia, the incidence is up to 2%. Whereas in solid organ transplantation, the incidence is very low and it is 0.07%. The most common solid organ transplant where we see mucor is renal transplant. Also, the other risk factors are treatment with deferoxamine, which is iron and aluminium chelator. It acts as a siderophore and supplies iron to the fungus, and the fungus just loves iron and it thrives on it, and you'll end up having a disseminated disease. The other risk factors are AIDS and injection drug abuse, as I discussed earlier. Trauma and burns and malnutrition usually leads to a disseminated, mainly a GI disease, which can disseminate it to different parts of the body. So how does they produce the infection? Let's look at that. So we all inhale spores of mucor daily, and they reach the turbinates and the alveoli. From there, if we have a normal mucosal defense system, because of the ciliary clearance, they would be taken to the pharynx, and from there they would be excreted through the GI tract. So that's what happens in a normal host. Anyone who has any immunocompromising condition or who has a poorly controlled diabetes or any other risk factor which I discussed in the previous two slides, uh, they do not have those normal mucociliary clearance, and the conidia reach the distal alveolar space, and over there they began to germinate. Now comes the role of macrophages, but we all know if there is an immune defect in the macrophages in poorly controlled diabetes, or there is a cell-mediated immune defect because of the glucocorticoid. So there is impaired migration and impaired phagolysosome, and the conidia just outgrows and they start developing in the alveoli. So, on top of that, if you add diabetes, there would be a diabetes or a diabetic ketoacidosis. There would be a lot of free iron available, and they can develop and multiply rapidly and convert into hyphal form. So now the next stage of immune defect is the neutrophil defect. So the neutrophil are responsible for attacking hyphae, and we know that the neutrophil migration is very poor in diabetes. So there is a poor neutrophilic migration, and because of diabetes or poor diabetic ketoacidosis, there is a lot of free iron available. So the hyphae just proliferate, and the neutrophils are not able to control the hyphae, and we have an angioinvasive growth in the tissue with hemorrhage, thrombosis, and necrosis. So this is how the defects in the immunity help outgrow our immunity and leads to an infection in immunosuppressed host. And now there are few micro factors also. One is, as I discussed earlier, iron uptake. It loves iron and it feeds on iron. And any situation where we have an iron overload in the body, they are at a very high risk for developing mucormycosis. So deferoxamine acts as an iron siderophore, supplies iron to the fungus, and it just proliferates like anything. Then there are a few other mechanisms which I would not go into in the detail. Next, we move on to what are the various syndromes produced by the mucormycosis. So one we have already discussed in the first case is the rhino-orbitocerebral. Second is the pulmonary. Third is the cutaneous, which we see after trauma or natural disasters. Fourth one is the GI syndromes, which are usually seen in those with malnutrition. Fifth one is the disseminated disease, usually seen in patients with intravenous drug abuse or who are on deferoxamine therapy. And of late, there have been cases of isolated renal mucormycosis in a completely immunocompetent host. So these patients would just present with or they would just present with flank pain, and they won't have any hematuria, they won't have any pus cells, urine cultures would be sterile, but they would have intractable pain, not responding to anything. And many times we just diagnose them on renal biopsies or end up doing nephrectomies for them. So with that, we move to the case 2. This is a 67-year-old male who's a known case of poorly controlled diabetes. Last A1C few months back was 11. Also has HIV with a CD4 of 548. Presented with fever and cough for the last 40 days. Right-sided pleuritic chest pain the last 30 days. And breathlessness for last 20 days. He had received multiple courses of adequate antibiotics to treat the community-acquired pneumonia, but he was not getting better. So that's when he came to us. Examination revealed there was a decreased air entry on the right infrascapular region, and infraaxillary crepes were also heard. So this was his chest X-ray. We can see a large consolidation on the right middle and lower lobe, and this X-ray on the this is the X-ray of the presentation. Whereas when we did an X-ray 3 days later, to our surprise, it had started to cavitate. And we can see a nice cavity developing or a necrosis developing in the center of the consolidation. So that's when we started to get worried, and we all love modern fancy imaging, and as a result of that, we did a HRCT which showed a large consolidation with a cavitation in that, and he ended up undergoing a lobectomy for that, because we had done a bronchoscopy and BL was negative. So he ended up getting a lobectomy, and this is what we can see on the video-assisted thoracoscope. We can clearly see that there was a lot of necrosis and a lot of blood oozing out, and Probably it was a severely angioinvasive fungus which we were dealing. The sample was sent for histopathology and culture, and as expected, we see broad aseptate fungal hyphae along with angioinvasion, and his culture, which was taken also, the TBLB culture before this thoracoscopic biopsy, TBLB was also done. Later on, that also grew Rhizopus erysus. So these are the various radiological findings in a patient with pulmonary mucormycosis. They can have nodular opacities without an air bronchogram. The image A shows a pleural-based, nice little nodule, and you can see surrounding ground glassing or a halo sign around it, which can be seen with both mucormycosis as well as aspergillosis. The only way to differentiate between the two is we can, the non-invasive way I'm talking here is galactomannan. The galactomannan would be elevated in a susceptible host in aspergillosis, whereas the galactomannan would be negative in mucormycosis. Otherwise, this pleural-based nodule with surrounding ground glassing opacity or a halo sign can be seen in both aspergillus as well as mucor. Then you have a reverse halo sign, in which you will have a central ground glassing surrounded by an area of consolidation, which you can see in image B as well as image D, which is very typical of mucormycosis. Very similar to what we were seeing in the case which I discussed just now. So mucormycosis in lung can spread to contralateral lung and even reach the chest wall, and you can have a reverse halo sign, which I discussed. So with that, we move to the third case. This is a 40-year-old male with a poorly controlled diabetes who is a post-kidney transplant for obstructive uropathy, has thermal burns, and this was the photo of his burn area, which he sent to us at the time of burns, on day one of burns. We said that this is nothing, you just apply a few things, and to all of our surprise, this is what was seen few days later. There was a large necrotic black ulcer, which has almost involved half of the abdominal wall, and he had to undergo a massive debridement by the plastic surgeons, and histopathology confirmed it to be mucormycosis. Fortunately, he did well later on, and it came as a shock to all of us when this had progressed over a few days. So this just points to the fact that mucormycosis is a very rapidly progressive fungus, and it just eats whatever tissue comes in its way. So mucormycosis can happen after natural disasters. There have been reports from US. 13 cases of necrotizing cutaneous infections were reported after a tornado in Missouri in 2011, and out of those 13 cases, 5 actually died. And genomic sequencing revealed the organism as Apophyzomyces, which is an expected organism when in this scenario. Next, we can come to the gastrointestinal mucormycosis. The host at risk are those who have malnutrition and the premature infants. And the common presentation is necrotizing enterocolitis. They can have peritonitis. They can also present like a mass-like lesion, especially around the appendix and in the ileum, especially distal ileum, which is very difficult to distinguish between TB and mucor in this current scenario. And the pathology is usually GI perforation and necrosis, and it is usually associated with very high mortality. Very few of the patients with gastrointestinal mucormycosis survive, and they would end up with a very short bowel syndrome, because most of the bowel will have to cut and remove because of the devastating disease it can produce. There are few reports of disseminated disease. They usually happen because of deferoxamine therapy, those who have neutropenia, those with acute leukemia, and post-allogenic stem cell transplant. In these cases, most of the time, the primary is the lung, and they have arterial occlusion by fungal thrombi of heart and bowel also is seen. There are few unusual cases like CAPD-associated peritonitis. In one lung transplant case, trachea was only seen to be involved. You can also have an isolated mediastinal involvement. Isolated bone involvement have also been seen. Also seen. Isolated kidney involvement, especially in an immunocompetent host, has also been seen, and I discussed that earlier. And those who have a bloodstream infection, especially those with intravenous drug abuse, infective endocarditis, have been seen in few cases. Now, how do we diagnose this devastating fungus? So first, we have to identify a host who is at risk, especially those who have any immune defect, those with diabetic ketoacidosis. And when we see fungal elements in culture and histopathology showing evidence of invasive disease, that's when we call it as invasive mucormycosis. So the global guidelines for the diagnosis and management of mucormycosis were released in 2019, and this is the algorithm proposed by them. They had proposed that whenever you have a suspected host, you do a cross-sectional imaging, preferably a CT of that suspected area, and the CT is done just to look at what all areas are involved, and then you sample tissue from an appropriate area. Send that tissue for fungal staining, fungal culture, and histopathology. Remember not to grind or cut the samples. And also talk to your microbiology and the pathology colleagues that we are suspecting mucor in this case. They would be more than willing to help you with that. Important point to remember here is that galactomannan, which is a marker for invasive aspergillosis, is negative in mucormycosis. And also the much talked about 1,3-beta-D-glucan, the also called pan-fungal marker, is also negative in mucormycosis. So we do not have any serological or non-invasive test to diagnose mucormycosis. The best way is to identify the syndrome early, get an appropriate imaging, and sample tissue and speak to lab. So cultures, we can inoculate them on fungal media, especially Seborrhoea dextrose agar. For staining purpose, we use chalcofluor white staining. Always inform the lab. Do not cut the specimen I discussed. On histopathology, I've already discussed. You will see a broad ribbon-like thin-walled aseptate hyphae. They would be well seen with HNE stain, GMS stain, and PAS stain. You will see a necrosis of the vessel with microthrombi, which suggests angioinvasion. Neural invasion may also be seen in 90% of the cases. Many times the pathology is neutrophilic or granulomatous, and they can also have a pyogranulomatous reaction. Role of PCR is very limited, and many of the centers do not perform it, and it needs to be standardized before we start using it. Now, how do we manage the mucormycosis? So we first need to understand few key principles in the management of mucormycosis. First is the timely diagnosis. Second, the most important is the reversal of the underlying predisposing factors or the immune defect. Third is the early maximum surgical debridement, because surgical debridement provides a mortality benefit, and it has been proven in studies that those who have had surgical debridement, the outcomes were much better than those who haven't had surgical debridement. Also, it is important to remember that we should have a rapid initiation of antifungal therapy in full doses. We should not be escalating the doses of amphotericin, which is very common practice with the physicians. We should not be doing that. So next we come to the antifungal therapy. There are two therapies. First is the initial therapy, then followed by a step-down therapy. Once we have achieved a good recovery of the patient, good clinical and radiological response in the patient. If the patient is not responding to the initial antifungal therapy, then we probably have to move to salvage therapy, which I will discuss later on. Early initiation of antifungal therapy improves the outcome of infection with mucormycosis. This has been illustrated in a retrospective study of 70 patients with hematological malignancy who had mucormycosis, in which delayed amphotericin B starting treatment 6 days after diagnosis resulted in an almost twofold increase in mortality at 12 weeks after diagnosis. Now, these are the guidelines which I was discussing for the management of invasive mucormycosis. The things on the things which I am highlighting here are strong recommendation or class A recommendation. The things in between are class B recommendation. things here are class C recommendation and things here are class D recommendation. By this, what I mean is that uh, we should start liposomal amphotericin B at the earliest in optimal doses. The dose can be from in between 5 to 10 milligram per kg per day. Remember, if we have a solid organ transplant recipient who has mucormycosis, the dose is 10 milligram per kg per day. And also those who have CNS involvement, the dose is 10 milligram per kg per day. Also worth remembering is that avoid slow escalation of the doses. This leads to wastage of time, and the fungus may even develop resistance to the drug because it is being exposed to suboptimal drug levels at a time when the inoculum is very high. So this is in based on this paper, the other therapies other than liposomal amphotericin which have been approved as initial therapy are isavuconazole, IV isavuconazole, and IV or oral posaconazole also. Whereas there is a strong recommendation against using amphotericin B deoxycholate or the conventional amphotericin, what we call. But however, there have been instances where we have to use amphotericin B deoxycholate because of the financial reasons, and India being a resource limited setting, many times we have used amphotericin B deoxycholate. But whenever there is no financial limitation, we should always go with the best possible drug in maximal dose, and that is liposomal amphotericin B. Depending on the scenario where we are using it, it can be in anything in between 5 to 10 milligram per kg per day from day one. So the first line of therapy, as I discussed earlier, is liposomal amphotericin B, grade A recommendation. POSA and isavuconazole, grade B recommendation. Syrup posaconazole is grade C recommendation. Few of the companies are now coming up with gastro-resistant posaconazole tablets in India, and very soon we'll have them in the market. Amphotericin B and local injection of retroorbital injection of amphotericin B is not suggested at all. Now, many times I've been asked this question by my colleagues, especially the transplant colleagues, what is the benefit of combination therapy? There are a few anecdotal reports where people have used a combination of amphotericin B plus casfofungin or a combination of amphotericin B plus voriconazole. But as of now, there is no strong data to suggest any benefit. All of them have been anecdotal reports, a very small case series, and the guidelines which I discussed earlier do not suggest using a combination therapy with the current available evidence. It needs to be studied in a large RCTs, and maybe we'll have the answer very soon in the future. So I'll just skip this. Next, we come to a few burning questions. And now, what is the difference in outcome for conventional amphotericin and liposomal amphotericin? Really, there are no comparative studies in patients with mucormycosis. However, I, in my personal experience, feel that using a liposomal form of an amphotericin is always better than a conventional form. For obvious reasons, you can give a higher dose. There are lesser toxicity, especially the nephrotoxicity and the bone marrow suppression with the conventional amphotericin. And also, we should remember in this fact that it has not been proven whenever we have a resource-limited setting or there are financial concerns, we can use conventional amphotericin, but with the caveat that the patient can develop a renal failure in near future because of the amphotericin-induced nephrotoxicity. The ideal dose for conventional amphotericin is 1 to 1.5 milligram per kg per day. For liposomal amphotericin, it is 5 to 7.5 milligram per kg per day. Higher dose needs to be used for CNS involvement and those with solid organ transplant recipients. Next, we come to salvage therapy, like when the patient has not responded to initial therapy as we have expected, like we should have a good clinical response. There should be a 25% reduction in the disease burden radiologically. So if we have not achieved, then we probably will have to move to salvage therapy. And what are the options we have for salvage therapy? The options are, as I discussed earlier, these are the two drugs which are part of the primary regimes also. These are posaconazole and isavuconazole. With posaconazole, the overall success rates have been around 60 to 70%, and isavuconazole achieved FDA approval for use for mucormycosis after the vital trial in which they had studied mucormycosis, isavuconazole used for mucormycosis, and compared with the fungal registry in which mucormycosis patients were being registered, and they found that the 42-day mortality was almost same in the two arms when we either we are using isavuconazole or liposomal amphotericin B. So after that, it achieved FDA approval for treatment of mucormycosis. So let's summarize the guidelines. Early, complete surgical treatment with clean margins and, if required, repeated debridement are strongly recommended in addition to the systemic antifungals. Amphotericin B deoxycholate is recommended against in view of toxicity, but the guidelines acknowledge it may be the only option in resource-limited settings. Strong recommendation to do away with slow escalation of the amphotericin doses. IV isavuconazole and posaconazole can be considered as upfront therapy in pre-existing renal disease patients. High-dose liposomal amphotericin of 10 mg per kg per day in brain involvement and SOT recipients, and 5 to 10 mg per kg per day in other settings, and doses of less than 5 mg per kg per day is only marginally recommended. Rather, it should not be used. De-escalation to oral isavuconazole or posaconazole tablets if there is partial response or the disease is stable. The treatment duration, which is most of the time asked by the transplant physician to us, how long do we treat? The treatment duration is individualized and should be until there is a clinical and radiological response and reconstitution of the host immune response. This is very important. Amphotericin B lipid complex 5 mg per kg per day is moderately recommended for patients without CNS involvement. Now, there are few adjunctive therapies, but none of them have been proven in clinical trials to be beneficial. There are few anecdotal reports of benefits with use of hyperbaric oxygen. I myself have used it in one patient with a good response, but the guidelines do not recommend it. And we can always use immune augmentation strategies like reducing the immunosuppression to the minimum in a patient post-transplant, or improving the glycemic control in a patient who has fully controlled diabetes. Now, this is very interesting. I keep coming back to the study done by my close colleague. Just look at these are three arms. Those who received antifungal alone, the mortality, cursor is not coming. It's coming. The mortality was 58%, those who received antifungal alone. And if you include progressive disease in that, the bad outcomes, which we can group together, is around 80%, those who received antifungal alone. Whereas for those who received surgery alone, the mortality was 20%. And if we combine the bad outcomes, like those who died and those who had progressive disease, the bad outcomes were around 80% again with surgery alone. When we combine both surgery and antifungal treatment, the outcomes improved and the mortality was only 24%. So this tells us that we should have both a combination of surgery as well as antifungal therapy. Antifungal alone, the mortality was 58%. Surgery alone, the mortality was 28%. Combination of the two, the mortality was 24%. So with that, I have come to the end of my presentation, and these are my few take-home messages. We should all have a high index of suspicion, try and achieve a timely diagnosis. Extensive and repeated debridement may be needed in most of the cases, and patients should be started aggressively on antifungal therapy. And all the combination of the three is the only way to improve mortality in these group of patients. Source control is of paramount importance and may need repeated debridement. Reversal of underlying immune metabolic defect to control the disease. Liposomal amphotericin is preferred agent of choice for the treatment of mucormycosis. POSA and isavuconazole now approved as first-line therapy as well as salvage therapy for mucormycosis. And we need to have a multidisciplinary approach for management of such cases. You need an infectious disease physician, you need an endocrinologist, you need an ENT surgeon. If you have a pulmonary involvement, you need a thoracic surgeon. So it needs a big team. And remember, it is not a cheap disease. It's a pretty costly disease to have. Thank you.